changed their name in 2012 to respond to the greater need of a more broad community and a more established one. Looking back to the time when the center was started in 1971, the issue was there coming out of the Indian relocation program of the 50s and 60s, aimed at teaching people a technical skill in an urban center and resettling many people at that time in urban population cores. The center's focus was responding to that dilemma that people faced upon arrival of not having their language, their culture, their foods, any of their customs or songs or stories told. And oftentimes, for that first generation, in some cases, having left the reservation, there was a lot of despair, a lot of dismay, discomfort, and even depression, which led to self-medication and people needing help. Urban centers got their start in a grassroots way to respond to that. And the center was no different. Around that time, many urban environments were experiencing this sort of renaissance in how to reach within our own communities and find the solutions for our people there. The original Indian Walk-In Center was just that, a storefront where you could walk in, find a couch, a coffee pot, a job board perhaps, and though we use the term navigator loosely now, you might find someone to help you navigate the community. So these early navigators would help people find housing, find jobs, get connected to other people in the community who could help bring some of those stories and songs and foods back into their existence, their being. We became very responsive and reactive to the the Indian Health Services grants that were available at the time, and our programs are primarily around direct medical health. It's often the pill in the shot mentality. You have a cold, here's a pill. You have pain, here's a shot. And then on the behavioral health side, depression screenings, outpatient groups, both intensive and general. We have an AA group that meets here. We do some family counseling and family preservation activities in the hopes of being relevant to those people in our community who find a lot of challenge in being away from their communities. We have a youth program that is based in using the best of both the health and behavioral health staff and their knowledge to create prevention curriculums to help them be aware and knowledgeable of the tools available, whether that's us externally or themselves internally, and things they know about what a healthy relationship is, and how to better self-identify culturally versus perhaps more locally with things like gangs. We want them to have the tools to avoid those challenges, and another area that we're hoping to have an impact is what a healthy relationship looks like between a man and a woman. Actually, we have no providers here. As a outreach and referral program of the Urban Indian Health Office of IHS, we have a contract with CHC, and individuals coming to us with a need for medical care are given a referral and are permitted to go and visit one of the CHC clinics for their services, both on the medical side and dental side as well. The vast majority of the funding for our center comes from the Office of Urban Indian Health Programs, the Indian Health Services. I would say we're probably 90 to 95% funded by IHS at the moment. Okay. We serve over 178 different tribal communities or tribal members on an annual basis, which is quite a significant amount of diversity. But we're no different than most urban centers. Some 78% of all American Indians now live in urban cities, and the tremendous diversity of the some 560 plus tribes is everywhere. The vast majority of the tribes that we see here locally, obviously you would expect that to be representative of the tribes here in Utah. And our service area goes from Provo to Ogden and out to Tooele, so we're 5 counties, Weber, Davis, Salt Lake, Utah, and Tooele counties are our service area. Most of the population being in Salt Lake County, and most specifically in the area of West Valley, Taylorsville, on the west side of the valley here. to a great extent, diabetes is still our biggest issue. It's still one of the biggest that's faced by the most. And I think along with that, some of the other things that we see are issues of obesity, which sometimes are co-occurring with issues of diabetes. Perhaps some of that's a lack of exercise or access to quality foods. I wouldn't necessarily say that we're certainly not in a food desert, but food insecurity is a massive issue faced by a lot of families who live in the city and have a hard time with income and economy. We still see that to a great extent. The issue is I think we can do a lot better job, and that's one of the things that we're working on through our strategic planning process as a result of the community assessment, is trying to find a way to partner with one or two additional entities to bring actual clinical services in-house. There was a time when that was the norm, and there are a lot of urban Indian health programs out there that do have clinical practices and services right in the center. We're working on that now, and that is the one place that I think that we could certainly see a broader relationship, as if we're able to bring more of those services like pediatrics or a general practitioner, even an advanced practice care nurse, to impact clinical outcomes by seeing someone in that moment. And certainly we want that to look, as we engage in this sort of information gathering process that we're on right now, we want it to look very unconsciously culturally competent. We want it to be with practitioners who understand this as Native people, who can engage people where they are, whether it's their economy, whether it's their family or their social experience, and treat them holistically. That's something that we're really pushing forward, and where we see that there could be some eventual relationship, hopefully. We're the center for things of health, behavioral health, physical wellness, youth programs, but we don't offer a lot in the way of social activity and coming together opportunities, sports leagues or language. We do have some more robust and growing cultural activities, but we can always do better. We can always expand those things. And it becomes for us a better picture of wellness that we hope practitioners, whether they're working for us in those spaces of just the direct clinical services, or coming and participating as a volunteer in those cultural spaces, where people are, I would say, less guarded than going into a doctor's office and not knowing what to expect. Oftentimes we find out the most about ourselves and our health ailments as Native people because we all have a story to tell. And it's not just in what's the symptom that's presenting, there's often a lot more behind it that in those spaces and conversation can be engaged. And a knowledgeable medical practitioner who's volunteering might say, hey, maybe you want to go see a practitioner about that. Maybe you want to go see a traditional healer about that. Imagine that. For us as Native people, the simple act of coming together, or coalescing, whatever the purpose, is a naturally cultural thing for us. To come together and problem solve, to communicate. It doesn't have to be drilled down or segregated into that beads and buckskin category that we're often trapped in as Native people. Almost trapped in our history, or trapped by our history, that recognizes those things from a romantic perspective and wants to keep us there. But there's no reason we can't have a group of new mothers that want to meet and talk with one another about formula and diapers and foods and what they're eating and getting back into their healthy fitness regimen, and imagine all of the information you could glean from that perspective as a healthcare practitioner provider, and just simply engaging people. And if you've got a lot of knowledge and can share that, you've got a group that's ready and open and willing to take that information and enhance their lives, and not just their own, but now their children, and other members of their family. It's